Hi, everybody. We're going to change directions a little bit. I want to introduce myself. I'm Jeff Spier. I'm President and CEO of Rio Grande Urology in West Texas and Southern New Mexico, and I'm Secretary of LUGPA. And Travis Mendel is joining me. He's the director of our Rio Grande Cancer Specialists. He's a radiation oncologist, and so I want to thank Dave Scott for this opportunity to present Advanced Prostate Cancer Pathways, the large urology group practice model. So this is a slide from Aaron Berger that we presented Sunday at our Vail Regional. I think it's really important to look at the historic perspective. We have two speakers, 10 minutes, we're gonna get this done. So we've got, prior to 2010, we only had a few options, as we all know. First generation anti-androgens, ketoconazole, or chemotherapy, and those of us that saw these patients die these horrific deaths, it was terrible. And then once patients progressed on ADT, they were referred to medical oncology. So the advanced prostate cancer concept became relevant with the introduction of oral options to include ABI and PRED. The PREVAIL trial introduced us to enzalutamide in 2014. And then that was the genesis of physician champions in large urology group practices that became more comfortable with this patient population through collaboration, education opportunities, as well as research. I don't think anyone's ever seen this slide, but those that have, I think it's more relevant than ever because, the urologist is now taking care of these patients throughout the continuum of care. But I think what's most important here is the start of therapy and what we have done and grown our practice. I mean, Dave Morris is a tough act to follow. He's a perfect example, and many of my colleagues are in this room that have really done so much to advance the care as general urologists and beyond, to include ADT clinics, bone health care, dental health, cardiovascular recognition. So, I'm really proud of my colleagues and the things we've done in independent practice. So why have large urology groups been so successful? First and foremost, prostate cancer patients are principally the patients of the urology practice. We've developed long-term relationships, the trust has been developed, and they sometimes want to stick with their urologists. We're quite capable of delivering the therapeutics that are available today. Increasingly, there are patient benefits and practice benefits to keeping these patients within the urology practice. And of course, the adoption of our pharmacy operations and dispensing operations have led to better patient control, education, pharmacists that can really get into the weeds on the side effect profiles of these drugs. That's really helped the practice in general. And we have a narrow focus. We're focusing on 1, 2, 3 spaces versus 156. So we've really gotten very good at what we do. There's been widespread adoption of administrative and analytic mechanisms to improve quality of care. So, we're very focused at LUGPA on the improved quality of care. And so, through collaboration education, combining data analytics, clinical pathways, and real world clinical intelligence, this has been our focus and the focus of the future. We believe in a multidisciplinary approach, and this includes medical oncology. I can speak for us in West Texas. We cover a huge swath of territory to include all of El Paso and Las Cruces. And sometimes we need to collaborate with our medical oncologists, and of course they become more and more relevant in our practice with the introduction of triplet therapy, the PEACE-1 and Ariston's trial. And the logistics of immunotherapy, some practices feel comfortable with it, others don't. So that collegial relationship is very important. And of course, I'm gonna hand it over to Travis, but the radiation oncologist has become critical in our practice. He is truly a colleague, a partner, and we work together to take care of our patients, to include the disease states of oligometastatic disease using SBRT, palliative radiation, and I'm proud to say that we've started Pluvicto, and of course Xofigo has been around for a while. So I'm proud of what we've done. I'm proud of what LUGPA has done. I'm going to turn it over to you, Travis. Go get him.
All right, thank you, everyone. Thanks for having me, and I need to thank my big brother over here. He's put up with my ridiculousness for about 3 years, and if you're wondering why he's lost all his hair color, I might have been the cause of that. So this is a quick slide just to kind of introduce the clinical pathways. So just to kind of give you the story, we're a very busy practice out in West Texas. We service probably over 1 million patients. And we're really the main urology group there. When I first started, it was, we didn't have it. It was a little bit disjointed. Everyone was kind of doing their own thing. And so we decided to sit down and develop these different pathways. And the idea actually came after a lecture from Scott. He came to El Paso and we were kind of sitting down talking about how he runs his clinic. how he thinks, how he puts his patients in buckets. And that kind of sparked the idea to do a very similar thing with our pathways. And so now this disease state is essentially a bucket. And so we have pathways that we use throughout the clinic, starting from active surveillance all the way to CRPC. And there's probably, at this point, maybe 10 to 12 pathways. But we're working on developing them for bladder cancer, renal cell cancer, and if you've got a problem, there's a pathway for it. So these are just a couple examples. I know you can't really read it. It's just different examples of the pathways that we have. These were developed several years ago, and so now with the advent of the PET PSMA imaging, it's really just completely changed my practice. And it's honestly changed a lot of our urology practice as well. It's led to, it changes what I do with the patient, it changes my planning, but it also causes a lot of confusion. And so what we've done now is we funnel all the PET positive patients to the cancer center so that we can evaluate the imaging and then decide where they need to go. So essentially, we figure out what bucket they need to be in, and then we kind of deliver the patient to whatever therapy is recommended for that disease state. So I can give you a couple examples. So say we have a patient who comes in and they've had radiation in the past, and now there's a local recurrence in the prostate. So that patient would come directly to my clinic. We would evaluate them. Usually I'd have them on, if they haven't had a biopsy yet, we'll have them on for biopsy the following week in my clinic. We'll do a targeted biopsy, maybe map some areas if we're planning on doing a salvage treatment to that. Usually for patients who have fluoride metastatic disease, whether they're castrate resistant or castration sensitive, usually my PA, who actually manages a lot of these patients, will see that patient, evaluate them, get them started in ADT, and direct them off to the APC clinic, which is what Jeff runs. So I think that this has been a great model for us. It's not a model for everyone, but I think that it's served our patients very well. And then this will probably help along the lines where right now we're developing a Agnostic Center, and so having these pathways is going to further help aid kind of direction for these patients in these different disease states. So they know where to go. We know where to go. The patients or the other providers in the practice understand, where the patients need to go. I'll leave it off to Jeff. Thank you.
Okay, so I'll just wrap it up. Thanks, Travis. So in summary here, the referral of the Advanced Prostate Cancer Champion requires the buy-in of the group, and it requires leadership. And at RGCS, we've developed protocols and processes where the partners do not dabble. It's sent to the people that do this the most. Application of clinical pathways are based on published guidelines. The use of data analytics and clinical intelligence, we always try to use these tools to improve the quality of care. And again, I can't tell you enough how important the multidisciplinary approach is. We are closer to San Diego than we are to MD Anderson in Houston and El Paso. Check Google Maps. So, I'm proud to say that we're able to keep our patients in that region, but when we need help, we reach out. So far, I think we've really grown this practice to include the following, nurse navigators, our radiation oncologists, of course, the diagnostic radiologists, and we do use nuclear medicine help as well. So with that, thank you all very much. I think we did a pretty good job with 2 presenters, Travis. Thank you all.